I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course. All right, in this section, I'm going to break down some of the more common viral infections that we can actually use medications for. I will also refer you to the vaccine section several times as well, because there are some vaccinations that are important. So first, we'll start off with influenza. It is very contagious, typically, respiratory droplet type transition. Institutionalized patients are at highest risk of transmission. Prophylaxis in an outbreak should be considered when we're talking about, enclosed areas, healthcare facilities, nursing homes, assisted livings, people's living in close quarters to each other. Vaccination, obviously important. I'll refer you to the vaccination slides on influenza vaccine. This virus does mutate quite a bit. So the influenza virus does change over time and adapt and those type of things. And so this is why we typically try to switch up the influenza vaccine each year, and why annual vaccination is typically recommended. Elderly and young are, typically the most vulnerable populations, obviously immunosuppressed as well. Elderly, I've seen a ton of cases where patients get influenza, let's say, and then they may start to get a little bit better towards the end of their course, and then, sure enough, they get a bacterial infection as well, corresponding with pneumonia. So that is something that definitely happens in our geriatric population for sure. All right, treatment. So CDC does recommend early antiviral treatment in people with flu symptoms who are 65 years and older, or otherwise at risk of developing serious flu illness. So, higher risk candidates, diabetes, cancer, immunosuppressed, young children, respiratory disease, I think is pretty common sense. I think probably what would be considered higher risk. So, pay attention to the patients that you're working with. And if you note that they're on, a bunch of medications, have this, condition, they're older, younger, those type of things, those are all important things to look for in assessing whether they should get some antiviral medication. All right, the medications. Basically, there's one primary one and one other one I see occasionally. The main one is oseltamivir. Brand name is Tamiflu. This inhibits the influenza's neuraminidase enzyme. Basically, what this enzyme does is allow for the release of new viral particles from infected cells. So obviously, releasing a bunch of new virus to go infect other cells helps the infection grow and get worse, essentially. And so by using a medication, we can kind of blunt that process and, hopefully help reduce the number of other cells that are getting infected by ultimately reducing kind of that viral load, if you will. Sooner the better. So if, you got a patient that's, 4 or 5 days removed from, the start of their symptoms, treatment is probably not going to do much for them at that point. Okay. So, those influenza courses typically run in the neighborhood of 3 to 7 days. We spike that fever. We get some achiness, chills. very, very commonly associated with influenza. Pay attention to renal function. We may need some dose adjustments there. If you see 75 once a day, it could be a couple of reasons for that. It could be dose adjusted for kidney function, but it could be for prophylaxis, which is typically recommended if we've got an outbreak type setting or situation in a healthcare setting where a lot of potentially frail, immunocompromised older patients are living in and around each other. All right, adverse effect profile. Probably two big ones I'd pay attention to. So GI, stomach upset, that can be relatively common. And then changes, psychiatric changes. So this is kind of a rare one that can happen. It's not crazy common, but it definitely is associated with oseltamivir. So, pay attention to that. Any, worsening signs of depression, any unusual behaviors, those type of things, oseltamivir can increase the risk for that. Valacyclovir is the other medication I wanted to mention. This inhibits the influenza virus cap-dependent endonuclease. Essentially, this blocks viral mRNA synthesis and prevents the virus from replicating itself. Indicated for both influenza A and B, single dose, so that's a really nice thing, versus oseltamivir, which is typically multiple doses over a course there. Dose is weight-based, so that's something you may have to get as a nurse. Like, okay, what do we need the weight for on the dosing here? And it's only recommended for treatment, and it's only for patients 12 years of age and older. Big drug interaction, super important. It's a one-time dose, so avoid the co-administration with what are called metal cations. So your calcium, irons, magnesium, zincs, it binds up the drug and it'll leave it, less effective than we would like it to be. So really important there on the patient education piece. Again, should be, fairly simple, fairly easy because we only got to give it one time to avoid the timing there. But it is important. Amantadine, I'm not going to cover too much. This actually has dopamine agonist action. It's considered an antiviral medication. Been a long time since I've ever seen it used for this purpose. It's generally used for other things, but I did put it on here for completeness sake. Hey, nurses and nursing students, want to reinforce pharmacology without boring old flashcards? Check out the Nursing Pharmacology Crossword Puzzle book from MedEd 101. It's an Amazon bestseller. It turns drug classes, mechanisms, side effects, and high-yield facts into fun, brain-boosting puzzles that help you remember what matters most. With over 2,000 questions and clues, it's perfect for study breaks, group review, or solo practice. This book makes learning pharmacology engaging. Grab your copy and start mastering meds in a way that's actually fun. Find it now at meded101.com/nurse. That's meded101.com/nurse. All right, moving on, shingles. So this is actually caused by varicella zoster virus. So it's the same infection that causes chickenpox. So basically your immune system suppresses this infection. You get it. Historically, it's received when you're a kid. You get chickenpox, those type of things. Obviously, we got a vaccine for that now. But your body is suppressing that. So if, as we get older, the immune system's not functioning as well, we get suppressed for some sort of reason, this increases the likelihood of that virus kind of creeping back up. And we can have an outbreak with that. And typically you're going to get a big red, painful, burning rash that's going to happen. Can be on the face, can be on the back, trunk of the body, and it can be super, super painful, okay? So pinpoint needles, so if somebody touches it, it can feel like pinpricks and that type of thing. The blisters can be like fluid filled, those type of things, kind of crust over. It can be really, really nasty for sure. Probably the most serious situation, other than, the severity of the pain, that can be really, really severe for some patients, is if it spreads in and around the face and to the eye. It can cause damage and blindness to the eye, so pay attention to that. One other kind of chronic complication we can have from that is called postherpetic neuralgia. That pain syndrome can stay and linger for a long time, and kind of continue to cause that nerve type of pain, even following the resolution of the shingles flare. So pay attention to that for sure. Risk factors I alluded to: older age, immunosuppression, and then vaccination. I've got this in the vaccine PowerPoint. Not going to double cover it there, but there is the information if you're looking for that. And then treatment. So pain management, and then antiviral medications. So similar to many viral infections, we want to get treatment started ASAP, as soon as possible for sure. The antivirals typically used for shingles. Valacyclovir is probably the most common I see in practice. We also have acyclovir and famciclovir. These medications are from the same class of antivirals. They inhibit viral DNA synthesis by metabolite being incorporated into viral DNA and disrupting its replication. Okay, it's kind of a unique mechanism there. Again, sooner the better, best within 3 days of initial onset. 7-day course is recommended for shingles. Acyclovir, probably the big reason why it isn't used very often is it requires multiple dosages per day. So, obviously that can be a problem for, patient adherence and those type of things. Valacyclovir, famciclovir can definitely be dosed less frequently, which is super nice. Valacyclovir actually is a prodrug which is converted to acyclovir in the body, but valacyclovir allows itself to hang around in the body a little bit longer and isn't cleared as quickly, so that half-life is a little bit longer and we can dose it less frequently. Adverse effects and liver issues are the two big things. Rarely, you may see some accumulation in chronic kidney disease, so pay a little bit attention to that, with neurotoxicity from these agents being a potential complication. Rarely, it can cause crystallization in the urine. If you remember from antibiotics, Bactrim is another example medication that could cause this. So again, taking with a full glass of water, making sure adequate hydration is happening is good. Pain management for shingles, I'll just briefly mention it here. Simple analgesics, opioids potentially in severe cases. If we've got that neuralgia, neuropathic type pain, you're definitely going to potentially see some gabapentin use or pregabalin. That's definitely common. If those are unavailable, not helpful, those type of things, TCAs, and we've got some topical agents too that could potentially help with some of that shingles pain. All right, and lastly here we've got some sexually transmitted viral infections. Genital herpes, HSV1 and 2 subtypes. Most genital cases are caused by subtype 2. Antiviral therapy is recommended for outbreaks, and again, same agents that we talked about with shingles. Genital herpes, shingles therapy, same antiviral medications there. Good patient education piece, avoid sexual intercourse or sexual contact when lesions or prodrome symptoms are happening. So sometimes patients can feel when an eruption's kind of coming on, and if that's the case, then they definitely want to abstain so they don't pass this on. HPV or human papillomavirus, another sexually transmitted viral infection. They can cause genital warts. We've got some topical type treatments there, and there's also some provider administered treatments that can be done in clinic and healthcare settings. And then HPV vaccination, definitely an important thing to look at and review. This is under the vaccine sections as well, which I went through.
Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the Meded 101 Nursing Pharmacology Review course.